Good afternoon. My name is Kiko Van Zant, and I'm a nurse in the rehab clinic here. And I have the privilege of being a member of the Duncan Planning Committee, which has over the years been amazing. So thank you very much, Dr. McLaughlin, for that privilege. And I have the privilege today of introducing Dr. Ross Hayes, who's going to be speaking on Pediatric Palliative Care, Lessons from the Seattle Experience. And I was looking over Dr. Hayes' CV, and I realized that I have known him for over 35 years, which means that we met when I was 10 and he was 12. No, not really. Not really. But seriously, he's the professor of rehabilitation medicine, adjunct professor of pediatrics, and bioethics and humanities at the University of Washington. He's the medical director of the palliative care consulting service here at Seattle Children's and the medical director of pediatric hospice and palliative care program through Providence Hospital of Seattle. Throughout his career, Dr. Hayes' expertise as a pediatric rehabilitation provider covers an expansive range of interests. So when I was going through his CV, I saw stuff on seating and mobility, cerebral palsy, Botox injections for tone management, early intervention, neuro-oncology, and progressive neuromuscular diseases. And this all includes a stint as the chair of the Duncan Award Committee from 1992 to 94. So he's kind of coming full circle here. His CV also shows extensive national and international work in the area of palliative care. And long ago, Dr. Hayes told me that it was his work in rehab with the progressive neuromuscular diseases that led him into his current work today as an expert in pediatric palliative care. Please join me in welcoming Dr. Ross Hayes.
Thank you. Let me just get through a couple of those. Yeah. Thank you very much for inviting me to come and talk about palliative care. I think it's an idea whose time has come, and I'm really happy to be able to explain a little bit about it to you. And I will say that this is the second time I've spoken at the Duncan seminar. I spoke here once in 1986. I was 7 at the time. It was sort of interesting being kind of a precocious third grader speaking at the Duncan seminar. But thank you for waiting 30 years and inviting me back. That's very nice. And I just want to say one other thing that I hadn't that I just need to say, and that is a thank you to Dr. McLaughlin. Because when I was a young faculty member here, kind of trying to find my way, Dr. McLaughlin really took me under his wing, taught me how to be a researcher, and I can't thank you enough for your mentorship and your friendship. So thank you so much for that. Palliative care, it means a lot of different things to different people. At this hospital, palliative care is a consultation service. In another setting, it's a board-certified medical specialty. But among other things, palliative care is an attitude. And when you think about that in terms of being multidisciplinary care for children and families in need, palliative care is something that you are all doing all the time. So I think that it's important to keep that in context, that palliative care is not a special thing. It's a frame of mind, and it's a way of caring for patients, and that you're all doing it. This is the best article ever in the entire world. And so I want you to pay attention. This was done by Jennifer Tamel at Harvard about 9 years ago. And it was a prospective randomized controlled trial where they had adults with a single diagnosis, which was small cell lung cancer. And they randomized them to 2 groups. The intervention group got early palliative care, and the control group didn't. And then they followed them until their death and afterwards. And what they found was that having early palliative care improved, quantitatively, measurably improved those patients' quality of life, that it reduced their symptoms, and this is particularly in the area of anxiety, depression, and for families post-traumatic stress were all reduced by early intervention with palliative care. And those patients who got the palliative care actually lived longer. You combine this study with work that our own Helene Starks from the University of Washington has done, which shows that early intervention with palliative care saves money. Then you have improved quality of life, you have fewer symptoms, you have longer life, and saves money. Who could ever argue with that? So, I just wanted to start with an argument that palliative care has proven itself to be an effective way of treating patients and an idea whose time has come. Well, what does it mean for children? Of course, that's what we're about here. And the Ann Goldman, who is a pediatric oncologist at Great Ormond Street in London, one of the pioneers in pediatric palliative care, talks about there are 4 different categories of children who might qualify. And so the first one is those children who have disorders for which cure is possible, but it may fail. And an example of that would be cancer. There are children where premature death is inevitable, but where treatment may prolong the quality and the quantity of life. So an example of that would be an inherited neuromuscular disorder. The third category are progressive conditions without curative options, where treatment is exclusively palliative but may extend life. So an example of that might be muscular dystrophy. Her fourth category are those children whose disorders are not progressive, but they render the children vulnerable and susceptible to life-limiting complications. And so that may be the type of patient that you're more likely to see, those children who have non-progressive neuromuscular diseases, cerebral palsy, traumatic brain injury, that sort of thing. The interesting thing about this is that if you add up categories 1, 2, and 3 in this country, the United States, there are 47,000 children that die in this country every year. And about half of those are going to be trauma or something where palliative care is not applicable. So it's about 24,000 children for whom palliative care would be an appropriate intervention. If you look at that last category, which I suspect is the one where you're more involved, there are 500,000 children in that category. And we're just beginning to get our hands around what their needs are and what palliative care really means in that setting. And we're lucky here now, we have a wonderful young researcher, Jory Bogetz, who's actually kind of dedicating her research efforts to getting an idea about what palliative care really means in the type of children that you all take care of. The World Health Organization talks about palliative care. It's multidisciplinary, and it includes not only the patient but the family, and that palliative care begins when the potentially life-limiting illness is diagnosed, and it isn't exclusive of curative care. In the best possible setting, they're both woven together. The National Hospice and Palliative Care Organization suggests that there are 7 areas that separate children from adults with palliative care. And these are wordy slides, so you can just close your eyes and not look at them. I'll tell you what's on there. But the first tenet is that children are not small adults. If you're doing adult palliative care, most people die when they're old. And so an adult is an adult is an adult. There are variations, of course, but generally they're technically the same. If you're doing pediatric palliative care, you're serving babies, toddlers, school-age children, adolescents, and young adults. The needs of a baby are going to be completely different from the needs of an adolescent. And so to do this in pediatrics, you have to have an appreciation for the wide spectrum of developmental changes that are inherent in this population. The second is that life-limiting illnesses in children are rare, thank goodness. That's a good thing. And they tend to be complicated, and they they change all the time. With newer treatments, the trajectory of illness and treatment is completely different. So for adults, you can use the New York Heart Association guidelines to have a pretty good idea of predicting what the trajectory of illness is going to be for a heart failure patient. And those are published, they're consistent, but there's nothing like that for children, because each child with a life-limiting illness is totally unique, and it makes it much, much harder to plan, to care, and to provide an accurate prognosis for them. These diseases are rare, and to treat them well, most of their care is regionalized. And so that and this hospital is a tremendous example of that if you have a rare disorder but you're from a rural environment, then the likelihood that you're going to be able to get the treatment you need in your hometown is kind of small. And so treatment for these disorders usually uproots children and families and separates them from their family, their social group, and most of their support networks. And that's different than it is in adults. Children don't have a legal voice, so we are always working with families and children. Certainly, if your patient is a baby or is developmentally disabled and can't speak for himself, then we regard the unit of care as not the patient; it's the patient and the patient's family. According to the Lancet, 50% of all childhood morbidity and mortality is embedded in larger socioeconomic issues. So things like access to primary care, prenatal care, ACEs, adverse childhood events, are all linked into our society and how we treat children, which is different than the way we see that in adults. Children have larger communities than adults. If you go to the funeral of a child, they're more often larger than funerals for older people, because children have a larger community. They have the school, the soccer team, the youth group, and all of their families' friends. Young families tend to be larger. And so the ripple effect of serious illness in children is much, much broader than it is in older adults. And the grief associated with serious childhood illness and death is completely different than it is for adults. People who study bereavement, who do research in bereavement, talk about grief and complicated grief. It used to be called pathological grief. But the idea is that there's sort of a normal expected time and process for grieving. And if it goes on beyond 6 months, or if it's occasioned by additional symptoms that go on for a long time, that's complicated grief. Grief after the death of a child is almost always complicated grief. There is no simple grief in that group. So those are 7 different ways that pediatric palliative care is not the same as palliative care in general. And so who are these kids? This is a study that we did here with a lot of our colleagues around the country, with Chris Feutner at CHOP in Philadelphia and Joanne Wolf at Harvard. And what we did, we had 6 robust pediatric palliative care programs. And what we agreed to do was just enroll every child who was referred to palliative care for a period of a year. And then, well, actually, we enrolled them for 3 months, and we followed them for a year. And we just collected all kinds of information. It was just purely descriptive. But the idea was, who are these kids? What are their needs? What medications are they using? Where do they come from, et cetera? And this was very interesting. If you just look at the diagnostic information, 40% of these kids had genetic disorders. Almost 40%, essentially 40%, had neuromuscular disease. And if you add up leukemias, solid tumors, and brain tumors, all those together are less than 20% of the total. We also followed those kids for a year, and after 12 months, after they'd been entered in a palliative care consultation service, 12 months later, 75% of them were still alive. So the take-home message, I think, from this study was pediatric palliative care is not all about cancer, and it's not all about the last 2 weeks of life. It's much broader, both in diagnostic categories and in the length of treatment or the length of stay in the program. Tenet of palliative care is improving communication and improving decision making. So I thought I'd just share a little bit with you about kind of where we've been and where we're going with this. This was a study done now quite a while ago by Jennifer Mack at Harvard. And what she did was she took care of children, primarily cancer children. And retrospectively, after the child had died, she asked questions of both the medical team and the family. And the question that she asked was, what was the most important thing? What was the most important thing that this family needed in the last month of their child's life? And families said what they needed was clear information, they needed sensitively delivered communication, they needed someone to talk to the patient himself, the child himself, and they needed preparation for death. These were the family's highest priorities. When they asked the medical team, what are the family's highest priorities, they said, less pain and decreased length of stay. Good intention, totally wrong. And when Jennifer compared these two, there was no correlation with what the families needed and what the medical team thought they needed. So clearly, we identified that there's a lot of work that needed to be done here. About language, this is Randy Curtis and Ruth Engelberg here at Harborview. Randy Curtis' name's going to come up a lot because he's just a marvelous researcher in palliative care, and we're so lucky to have him here in Seattle. But a while ago, this is in adult patients, but they analyzed care conferences where the medical team, particularly in the ICU, was meeting with families, and they just, they didn't really announce themselves as having any agenda, they just took notes. And what they found was that the physicians asked the family if they're ready to hear information 2% of the time. So 98% of the time, there was no warning about what was coming. And after they were done, they checked to find out whether the family really understood what they had said 14% of the time. So 86% of the time, they left the room and assumed that the family knew what was going on without ever asking. And so what happens with that? 90% of the time, the family doesn't believe what we told them because they haven't been prepared, and we never thought to check with them afterwards. So there was plenty of work here to do. And how do you do that work? Well, like if you want to get here, right up here, anybody ever been to Angelina in Paris where they make the hot chocolate of melted chocolate bars? Yeah. If you haven't been there, you need to go. Everybody, you need to go there. Right. So Angelina is right up there. And if you're staying in a hotel down here someplace, there are two things that you need. You need to know where Angelina is, and then you need to figure out how you're going to get there. So you need to have an objective, and you need to have a pathway to get there. So speaking of France, here's another study from France, from Paris. This was an ICU study looking at palliative care, and they had by this time recognized that there was work to do. And so, again, this is sort of interesting because this came from Paris, ICU group. Elie Azoulay really is the first author, the head of this whole group, but look at all these names: Joly, Bernard, Gaillon, and Randy. Randy Curtis, there again. Was participated in this study, but here's what they did. Again, this was another nicely designed prospective randomized controlled trial. They had 126 patients in the ICU, and the eligibility was that the attending who was taking care of that patient believed the patient was probably going to die during this admission. So that's how they chose their patients. They randomized them to one group that where they actually planned out what they were going to say. Not the exact details, but we need to find out what the family understands already, and then we need to talk about what we think is going to happen, and then we need to ask them if they understand it, that sort of thing. And they put together a little brochure that just prepared them for death, basically. Like 8.5 by 11 sheet of paper. That's all they did. So they thought through what they were going to say and how they were going to respond to the family, and they put together a little tiny brochure. And look what happened. They queried the family members 3 months after the patient died, and there was less anxiety, less depression, and less post-traumatic stress related to the experiences of the patient and the family in the intensive care unit. It doesn't take that much to improve what we've done in the past. The other area, and I'm just going to talk very briefly about this, is shared decision-making, which is a big part of palliative care. You know, along the way, there are often very important branching points where you have to make a decision about whether you're going to continue on chemotherapy regimen or not, or whether you're going to accept a phase 1 clinical trial or not. A big one that comes up with patients that you know is a family, is this appropriate to recommend tracheostomy and long-term ventilation? You know, there are all these huge decision-making points, and we have to pay attention to that. So the factors that go into decision-making are, you know, what is the medical fact here? What's the prognosis? How sure are we that we're correct? And what's the family side of this? And the players are, again, the patient and the family, and on one side, and the medical team on the other side. So this is kind of what this might look like. This is kind of the paradigm of decision making. And if you look at it, paternalism is over here on this side. This is the medical team decides everything, and you just accept it, which is not uncommon 50 years ago in this country. And the other side over here is more, it's healthcare consumerism. This is where the patient decides, this is what I want, and I'm really coming to you to get what I want, not necessarily to get your opinion. So the extreme examples of this would be over here on the paternalism side. This would be my birth, when my mother in was in labor with me, and she was told, we're going to deliver your baby under general anesthesia. You don't have any choice in this. This is how we do it, and that's how I was born. My mom didn't have any say in the fact that she was completely knocked out when she went through labor and delivered me. So that's paternalism. Way over here on the other end of autonomy or consumerism is, I'm not going to have my child vaccinated because Gwyneth Paltrow told me it was wrong, you know, which is actually not a joke anymore. So on what do we have on this side? Prognosis and certainty. This belongs to the medical team. And on the other side is the family's wishes and the family's understanding. That belongs to the family. And clinical decision making really has to be an arbitration of those two. And this is becoming very interesting now. If some of you may know Doug Opel, who is in the Truman Catt Center for Bioethics, he's done some beautiful, beautiful work looking at this whole thing in 2018, 2019. And what's interesting is that if you are more paternalistic, and a really great way to study this is immunization practice. If you're more paternalistic, health outcomes are better. Patients do better. Patients are healthier if you're kind of more on this end. Whoops, wait a minute. If you're more on this end. If you're on this end, families are more satisfied. People are happier if they come and say, oh, you know, I came to see Dr. Smith, and he basically said, well, you know, I think we should immunize your baby, and we said, no, I don't think we should, and then, you know, we kind of negotiated that, and actually we're not going to get him immunized until maybe a little bit later. That actually is associated with increased patient satisfaction, poorer health outcomes, but better satisfaction. The interesting thing that for us as providers now, we're being incentivized on both ends. People are studying health outcomes and they're studying our patient satisfaction. And we're caught in a very interesting bind here with clinical decision making. the best way to, I think, to really arbitrate this is a shared model. And this is another study that was done a while ago, but the idea is that I think everybody is most satisfied if we have a shared decision between the healthcare providers and the family. And people are probably the least satisfied in a paternalistic point of view. But this is a really interesting shifting landscape. What we do here at Seattle Children's is we use a conceptual framework that's based on an ethical decision-making tool, where what we do is we talk about the medical indications. In the old days, this was 90 to 95% of the conversation. This is the medical team talking to the family, saying, this is what your diagnosis is, these are what the treatment options are, this is the risk and benefit, and okay, now we'll leave you 2 minutes to respond. But we, in addition to that, we also add this. What is the patient and family preferences? And using a tool like this or a reminder like this helps us to remember that the family has a say in this and that we have to give them an opportunity to tell us what their preferences are, and we have to listen to it. We also pay attention to the quality of life issues, like how is this decision going to alter my child's quality of life? If you have a 5-year-old who loves going to school, who gets all of his strokes being in school, then you might want to choose the chemotherapy regimen that's going to give him the highest likelihood of being able to go to school. Or if you have a teenager who says, you can do anything you want to me, I just don't want to lose my hair. You know, that's a quality of life concern that we would never know if we didn't ask. And so using this type of a decision-making tool helps you to remember that. The context is, who is this kid? Who's this family? Where do they live? Do they have health insurance? What are the consequences of this illness in the context of their community? And that plays a part too. You put all those together, they help to create a meaningful discussion, which then goes on to become a care plan. So this is one way that we've, I think, experimented with here. And I not to make this talk too long, I didn't include all this information, but we've actually subjected this to some scientific scrutiny and have been able to show also that we can improve patients' and families' quality of life by using this kind of a decision-making model. Okay, 5 domains of palliative care. Just talk a little bit about this, just to give you an idea of kind of what the conceptual background is. I look at it this way, and you can slice this pie any way you want, but there's the physical domain, the emotional domain, social, spiritual, and family domain. And we'll just go through each one of those and talk a little bit about them. The physical domain. Joanne Wolfe, again, our colleague at Harvard and at Dana-Farber, studied this a while ago. She's a cancer doctor, and so she talked to her families afterward about their experience of pain at the end of life. 90% of patients had substantial suffering at the end of life. Greater than 80% of them said they'd been treated for pain, but less than 50% said that they had been adequately treated for pain. So half of these children were suffering pain when maybe we could have done a better job. This was now almost 20 years ago, and we have made significant improvements in pain and symptom management here. But it's a continual project. One of the biggest barriers is education. We still have residents and young doctors and families who are afraid to give pain medication because they're worried that their 3-year-old is going to become an addict if you use morphine at the end of life. The whole opioid epidemic is complicating things further. So we make 3 steps, we move 3 steps forward and 2 steps back, but we're continuing to make progress with much more sophisticated management of pain at the end of life. And we're learning more as we go along too. You know, 20 years ago, we didn't know that there was such a thing as opioid-induced hyperalgesia, which is this rare disorder where the more pain medicine you give, the worse the pain gets. And now we know that you by rotating medications, and particularly using methadone, you can get away from some of that. So we're making progress, but we still have a way to go. There's the domain of the family. And this is Patterson's theory of family adjustment. We did a big NIH-funded study in the ICU here several years ago, and this was the conceptual framework that we used. And you don't have to remember any of this except for the fact that families come into us. Families come into this thing here. They move through and they go out this way. They come to us here. We don't choose who they are. We don't get to choose who these families and these patients are. Some of them have a lot of resources. Some of them have a lot of medical sophistication. Some of them are coming without any of that knowledge. Some are coming with very limited resources. Some are coming with tremendous bias that's created all over our culture and our society. We don't get to choose who they are. Our job is to provide service for them regardless of who they are and where they came from. And so we interact with them, and then they move on. And in the cases where the patient, the pediatric patient, doesn't survive this illness, then that patient is no longer going to be affected by this, but the family members are going to live with this experience for the rest of their lives. And so how we treat them makes a difference whether the patient survives or not. Spiritual. You know, we're all spiritual beings, and certainly illness, serious illness, death and dying are physical, social, emotional, and spiritual experiences. And as medical providers, we suck at talking about this with our patients. Elaine Meyer, who's another wonderful researcher from Harvard, works in the ICU primarily, did this study where she contacted families after their children had died in the intensive care unit and asked them a similar question to Jennifer Mack, which was, what were your highest priorities? What was most important to you and your child's care in the last 3 weeks of life? And so the family said that what they needed was honest communication or complete information. They needed the staff to be available to them. They needed care coordination and quality in the communication. They needed the staff who was taking care of them and their child to be open about their emotion. They needed to share that with the families needed to share that with their staff. They needed to preserve the integrity of the parent-child relationship. So, and we do a good job of that here, I think, by, you know, having opportunity for families, parents to room in and more flexible visiting hours and that sort of thing. But wanted to, in the course of all of this complicated medical management, to keep the relationship with the patient and the family at the center of the care. And they wanted someone to acknowledge their faith. It's not a small thing, like 73% of them wanted this. And we almost never do this. There's a lot in the adult literature that says that, particularly in internal medicine, this is an area that's important for families and we just don't touch it. If you look at the medical education literature, like how do you educate medical students, what you find there is that taking a spiritual history is just about as difficult as taking a sexual history. And there's a good reason for that, because your sex life is intimate. It's part of the center of you. And your spiritual life is similarly intimate. And we don't very often get at that. But when you do, it's surprising how that affects the relationship between you and your patient. These families in Boston where Elaine did this study, they said, I don't need to have my doctor believe what I believe. I just need them to understand who I am. And I need them to appreciate what I believe. And, you know, this is an area where we have plenty of room for improvement. And the social domain. This is, I think, you know, this might be the most important thing that I have to say today. And here it is. So there's this idea of cultural competence. You know, cultural competence, if you know, I'm not supposed to read slides, but if you look at this, the last sentence is, it requires mastery of lists of different cultures and particular health beliefs and behaviors. And I'm not saying, I don't want to be misunderstood, I'm not saying that cultural competence is a bad thing. It's a good thing. There was a time when we had no concept of this, and I think things really changed around 1964 when we began to pay more attention to human rights, to civil rights, and that sort of thing. And we began to realize, hey, we're not all alike. And so we probably would do a lot better if we tried to understand who each other is. And so we've made quite a lot of progress in the last 50 years. But this idea that cultural competence is mastery of lists of different cultures and particular health beliefs and behaviors has a problem. And I think a better way of looking at this is this idea of cultural humility. Cultural humility is talking about stepping away from the comfort zone of being an expert and acknowledging when we might not know a patient's culture, becoming a student of that patient, learning about who these patients are, including their beliefs, their expectations, their values, and what quality of life might look like to them. It entails a lifelong commitment to self-evaluation and critique. If you look at cultural competence, I might have a Korean patient, and I may have lived in Korea, and I may speak Korean, and I may know all about Korean culture, which is great. That's going to give me a leg up in understanding who that person is. But what does that say about that individual human being sitting across the desk from me? It doesn't go far enough. If you reverse the situation, I could be an American in a Korean hospital, and my medical team could speak English. They can know all about American television and American Idol and hot dogs and all that stuff. But what does that say about me as an individual person who's sick and needing their help to understand my illness? So I think that cultural competence as an overarching principle is largely mythical. And I think that this idea of cultural humility, that is, basically, I need you to tell me what I need to know about you so I can do a better job taking care of you and your family, I think is probably a better way to go. And there are people, and even this concept is not perfect. There are people from other cultures who would say, hey, I'm sick. I don't have the time and energy to provide this education for you, And I get that. I think that's true too. But I still think this is an improvement over the kind of false mastery that comes with the idea of being culturally competent. This is huge in palliative care because we are meeting patients at these very critical moments in their illness and in their lives. And unless we understand this, we're going to miss the boat a lot of the time, and patients are going to suffer more than they need to. And if you talk about culture and crossing the cultural divide, there's a difference between me and my Russian-speaking patients because I don't speak Russian and I don't have a Russian background. All those things are true, but there's no greater divide than the difference between the medical culture, which is what we practice here with our own language and our own jargon and our own ways of doing things, and the individual family culture, where they may or may not understand any of that language, any of that jargon. They may not even believe in what we're doing. So the biggest cultural cavern is between the medical culture and the culture of the individual family. And then the emotional domain. I tend to sort of break this up into three different categories. In the emotional domain, there is denial, anger, and engineers. And I'll start with the easiest one first, and that is engineers. This used to say engineer dads, and then I found the slide. I thought, of course, it's engineers. It's not engineer moms or dads. But the idea of the engineer is that engineers are generally really smart people who are good at analyzing things and breaking them down into their parts. And for them, having a difficult problem to solve is really energizing. It's great. The problem is that when you get to a place in medical care where you have this awful discussion where you say, we're at the end of the road. We don't have any more curative treatment. This is what it's going to be. You know, that's difficult to begin with. But if you have an engineer who's used to looking at problems as a puzzle to solve, they're more likely than not going to look at you and maybe in a polite way say, oh, doc, if you were just a little bit smarter, you know, I think we could solve this problem. And I think knowing that, being prepared for that is an important thing. The other side of it is nowadays our patients and their families pretty much know what we know. I mean, at least they have access to that information, for better or worse. We all have had experience where it's worse, but there's sometimes when it's better. You know, I can give an anecdote about a patient who had persistent seizures, was in a pentabarb coma in the ICU, and every time they would try to wean him off the pentabarb, the seizures would come roaring back. And his mom and dad were both computer scientists, and they were so thoughtful and gracious. But we were in this care conference where we were just kind of stuck, and nobody really knew what to do. And the dad said, you know, I spent a little time on this, and I kind of developed my own algorithm. And, you know, I think the interval between the dosage changes is too short. And I think if you lengthened it by another 20%, we'd probably do better. And the first reaction that was about to come out of somebody's mouth was, oh, yeah. But you could just go around the circle and see everybody going, oh, yeah, he's right, you know? And I think that if we don't pay attention to that, we miss out too. Sometimes our families are ahead of us. Many times what they've gotten from Dr. Google is a big problem, but sometimes they really are ahead of us, and we ignore their advice at our peril. So engineers, anger, I think it's, you know, as providers, we're a lot more comfortable with the gracious, gratitudinous family than we are with the angry family. You know, that's harder for us to deal with anger, but it comes up. And I think it's helpful to understand that most times anger in this setting is a proxy for fear. If your child is seriously ill and in the care of other people in this hospital, you have a good reason to be afraid. If medical errors occur on an average 1 every 48 hours for every patient who's admitted to a hospital, and we have 230,000 unnecessary deaths in this country every year from errors that occur in the hospital, then their fears are real. And and if you're a mom of a patient who's here, the first time you see somebody try to hang the wrong chemotherapy agent on their IV pole, you become hypervigilant. And then you have a DSM-5 diagnosis. You are certifiably crazy. And we, with all of our good intentions, and there's no one to blame for this, but my personal opinion is if your child is sick enough to be here for a month or longer, we take perfectly normal people and we drive them crazy. With our high stakes, high tech environment here, we just drive people crazy. And then because they're crazy, they do inappropriate things, and then we want to punish them. And so I think it's just important to remember that when you get that angry patient, some of it is coming from a very logical experience of fear. And knowing that sometimes helps to make you a little bit better prepared and less defensive. And denial. We don't use this term very much. The best way for me to kind of explain that is with an anecdote. Quite a while ago now, we had a nurse manager of the palliative care team, Michelle Frost, who just had this tremendous insight into people. And we were in a situation in the ICU where we had a teenage girl who was very close to the end of life. She had 5 organs failing, and it was really time to discontinue the ventilator. And I think everybody thought that we weren't treating this child anymore. We were only prolonging the suffering, and it was time to stop. And every time they would bring it up to the mom, she would say, absolutely not. I will not allow you to do that. And the harder they would push, the more she would dig in. And it got to the point where in all the break rooms, every shift, people were talking about this mom's denial. We've got to break through her denial. She's in denial. Michelle just spent some time getting to know her and said to this mom, do you ever play the tape of your daughter's funeral in your head? And this mom said, every day. She wasn't in denial. It wasn't that she didn't understand what was going on. She wasn't fact deficient and needed more information. Actually, providing more information was only making the problem worse. She needed someone to understand where she was. She was existing on two different planes, she knew her daughter was going to die, but she could not be the one to say, okay, it's okay to stop. She didn't want to live with that for the rest of her life. She was looking at the situation from two different points of view at the same time, which is what we all do. That's Einstein's theory of relativity. That is Picasso in Cubism. I mean, we all do that all the time. And if we understand that better, then I think that we can do a better job for these patients. And the problem with calling it denial was that when that was going on in all those break rooms everywhere, it objectified this mom in a certain way. If you say, oh, she's in denial, it puts her in a category where she's a little bit mentally off and gives people permission to pay less attention to her at exactly the moment where we need to be paying more attention to her. So we don't really talk about denial very much anymore. It's better to think about it as unrealistic but necessary hope. I think sometimes that's what families need. This is a very intimidating environment, and if your child is really, really sick, it takes a lot of courage to get out of bed and tie your shoes and come in here and face all of us every day. And sometimes you need that hope to give you the energy to come and do that. Okay, let me leave you with three things. Practical advice. Number one, sit down. There's a study a long time ago, you've probably heard about it before, on surgery rounds, where a surgeon went on rounds in an adult hospital and had a researcher with a stopwatch who made the surgeon spend exactly 5 minutes with each patient. Half the time standing up and half the time sitting down. That research assistant came back later in the day and said, how long did Dr. Smith spend with you? And they were usually, when the doctor was standing up, they said, oh, I think he was here for about a minute. And if he was sitting down, they often said, I think they're here about 20 minutes, And so it makes a difference. When you're sick, you're vulnerable. And if you're lying down and there's somebody standing above you talking down to you, it matters. Another genius nurse that helped train me in palliative care, Jerry Haynes, used to say, when you have something important to say, your heart should never be higher than their heart. So think about that. They'll never remember what you said. They'll always remember how you made them feel. This is not new to you, but it's really true. You have a second chance at information. You don't have a second chance at a first impression. And if you get off on the wrong foot, it's much harder to repair. This is always important to keep in mind. They may not remember what you said, but they'll always remember how you made them feel. And then the last thing is 3 more things. So people need 3 things. They need the truth. In different cultures, that's not valued as much in this setting. That in certain places, you don't talk about the fact that you have a diagnosis of cancer. But in this culture, in our culture, people need the truth. They don't need brutal truth. They need sensitively delivered truth. And they also, once they have the truth, they have a burden to bear. They're on a journey. And so they need someone to walk with them. This is how our palliative care service is designed in this hospital anyway, is that every patient has a continuity consultant so from the time we meet them until the time they're either cured, and we're the second happiest people if they're cured and they walk out of here, or they're discharged or they die, they have the same consultant who's with them the whole time. So they need someone to walk with them. And that might be you at some time. And then the last thing they need is hope. And there's kind of an old traditional hospice adage about hope, and that is that it doesn't change. Hope doesn't change. Hope doesn't go away. Hope changes. Sorry, I said the wrong thing. And so an example is, in the very beginning, you have a hope that it's a lab error, and that wasn't your MRI, that was somebody else's MRI, or that you're going to wake up and this nightmare is going to be over. If that doesn't turn out to be the case, then you're going to hope to be cured. And if that doesn't end up being the case, that you're not going to be cured, then you hope that you're not going to have too much suffering at the end. And at the very end, you hope at least that your life has had meaning. And that's an important hope. And for children, there's another step, which is that parents of children who die hope that their children will continue to do some good in the world. We all do. All of us who are parents have this hope that our children are going to do something good in the world. And parents whose children die set up things like the Jimmy Fund or Gloria's Angels or the Bentown Foundation so that their children can continue to do good work even after they're gone.
Hi, Russ. Good talk, but I need a conclusion to your denial story. Was it the mom wasn't in denial, but did she need the doctor to tell her it is time?
No,
Did she need that, or?
She needed someone to acknowledge where she was and what was going to happen next. And then she's the one who said, okay, I think it's time. People needed to understand her, give her a little space, and then she could be in control. It's very interesting how these things happen. I mean, sometimes it's like, you're at this impasse, and there's some little conversation, and then things change. And I think that it's not always true, but sometimes the harder you push, the worse you make it.
I actually have a question. I'll get to you right away. So I appreciate your expanding on the definition of palliative care as the bulk of the kids are not necessarily end of life.
Yeah.
And, I'm wondering what your experience is when you talk to a family about palliative care, where they may have the idea that it truly is end of life care.
Yeah.
And how do you handle that? How do you bridge that gap of knowledge?
We've been working on this for a long time, and we still don't have it right, I don't think. I don't know if you've been paying attention to us around here. We were the palliative care service, and then, and my view of that was palliative care is a good thing. It's not a pejorative. It's not, shouldn't be scary. And so we should just deliver it sensitively, do a good job, call it what it is, and the problem will solve itself. That was my view. And 10 years later, when I had an oncologist come and say, well, I'm sorry, we're referring this family too late, but we just couldn't use that word palliative care. It's just too scary. I said, I give up. And so we changed our name to PACT, Pediatric Advanced Care Team. And we chose that because it's okay to steal if you steal from the best, and that's what they use at Penn, and that's what they use at Harvard. So we said, okay, well, that's what we'll use too. So we became PACT, which was never very comfortable because you can have a business card that says PACT on it, and you give it to a family, and they go, what is that? And then you end up having to describe it anyway. And I think you run the risk of families feeling a little bit deceived, like, why do you have, why don't you just tell me what you're doing? Why do you have this funny acronym on your business card? And one thing led to another, and we decided to change our name back to palliative care. So now we're the palliative care service again. Hang on, later, we may be something else. Michelle Frost, that woman, that nurse that I talked to before, used to say, you know what, you can call us PACT, you can call us palliative care, you can call us SpongeBob. I don't really care. Just let me meet the family, and if once they understand I could be helpful to them, then it doesn't matter what you call us. I wish it were that simple. It is sometimes, but we often go to a family and we say, we're the palliative care team. What that means in this hospital is that that your child is ill, and that we are an extra layer of support for you. and we'll provide as little or as much as you need. You know, if you don't need anything, that's great. But if we can be helpful, that's what we want to be. And then just develop a relationship, and eventually, it doesn't matter. But it's a continual issue. You know, I don't know if in my lifetime in this career I'm going to see it resolved, actually. But yeah.
So Ross, that was an excellent talk. Appreciate it. I want to particularly underline, because I think it was so important what you said about cultural humility. It really is just ultimately getting each kid, each family to tell their own story.
Yeah.
I can think of so many ridiculous examples on the other side, but that's really a very critical piece.
Yeah. We last July we had a national symposium here talking about that, about pediatric palliative care in the multicultural context, and it was all about how do we implement cultural humility. It continues to be an area where we need to do a lot of work.
I have
Yeah.
one thing I'd like to say too. Good job. It's really wonderful. One of the things that you mentioned is how you walk with a family. I try when I'm with my patients to sit with my families and not sit across, but sit next to, sort of partnering, facing the same direction, and that helps me partner with them.
Yeah. Very good.
All right. Thank you, Dr. Hayes.
Yeah, thank you.